Good morning, fellow panelists and distinguished audience seated in this satellite session. I am Dr. Dennis Onotu, a pediatrician and the branch chief of the Continuum of Care and Treatment branch, CDC, Nigeria. First,
All right. Good morning, everybody. Thank you so much for being here. Great. Good morning, everybody. Thank you for being here. Lovely to see so many people here bright and early at the end of a great conference. And whilst we're in the final stretch, I think this will be a stimulating and rich opportunity to hear about how different stakeholders are considering the challenges and opportunities related to how we integrate NCD programming into HIV care. My name is Mike Reed. I'm Chief Science Officer at PEPFAR, and I bring greetings from the PEPFAR family back in DC. We are deeply committed to considering how our HIV programs can support countries as they seek to deliver client-centered care for people living with HIV. And it's in service of that commitment that we're hosting this session today. I don't think I need to tell any of you in the room how important it is to consider the need to integrate NCD care into routine HIV care for people living with HIV. There are over 20 million people programming. About 25% of people living with HIV on antiretrovirals have concomitant hypertension. And that raises really important questions around how do we optimize clinical outcomes for these people in addition to supporting their HIV outcomes in terms of ensuring that their blood pressure is optimally controlled, but also responding and helping address their other comorbid conditions. So it's within that context that we are really delighted this morning to bring insights from 3 different country programs. We switched up the order a little bit. We're going to start with a presentation from colleagues in Nigeria who are going to highlight some of their some examples of the models for integrated service delivery in Nigeria, and then we'll hear hopefully from Kenya and then finally from Zimbabwe. Each of the presentations is 10 minutes, and that will give us ample opportunity at the end for discussion and for you all to share insights from your own settings. One last thing before I close is just to highlight the fact that whilst PEPFAR's focus will continue to be on HIV service delivery and ensuring that we help all of our partner countries achieve 95, 95, 95, we know that our programs have to transform to address the challenges of NCDs. And early in the new year, we'll be launching a program to support optimizing high blood pressure control amongst people living with HIV. It's just one example of that commitment. But without further ado, I'm going to ask our technical team to run the video, and we'll hear from Dr. Dennis Onotu, who is the CDC Director of Care and Treatment in...
Good morning, fellow panelists and distinguished audience seated in this satellite.
Let's go.
Good morning, fellow panelists and distinguished audience seated in this satellite session. I am Dr. Dennis Onotu, a pediatrician and the branch chief of the Continuum of Care and Treatment branch, CDC, Nigeria. First, I want to specially appreciate the GHSD PEPFAR team that put together this session and for extending invitation to share lessons from Nigeria. And special thanks to Rita and Kati. I'll be making this presentation using the following outline: background, integration models, monitoring and evaluation, results, and next steps. Background and evidence. People with HIV live healthier and longer, hence share similar burden with the general population. NCDs are responsible for about 27% of deaths in Nigeria, whose population is about 200 million, and a HIV prevalence of 1.4% and approximately 2 million persons living with HIV. In 2022, PEPFAR program data reveals that 41% of PLHIVs on ART are 40 years and above, and the mortality was disproportionately higher in patients above 30 years, with those above 50 years accounting for 30% of the death, despite a treatment success, as evident by a very good viral suppression. This is the basis for the need to have care beyond ART and the conceptualization of the one-stop shop model for HIV and NCD provision. The developing our HIV NCD integration model. This model was developed through stakeholders engagement, assessment of facility readiness using the WHO SARA tool, while we assured the design was context specific and evidence based, and also client centered. Health facilities were equipped, health workers were trained, and we put in place a robust monitoring system for the implementation and generate data that provide evidence for program improvement and scale up. Part of the assessment findings include during the baseline assessment include lack of adequate medical supplies, SOPs, IICs, and or guidelines. And we also noticed that most healthcare workers have not received training in the management of NCDs in the last 2 years. And the model of the one-stop shop model leverage on robust and existing resources provided by PEPFAR for HIV care and treatment in order to power the chronic care model. The one-stop model provides health promotion, prevention via integrated health messages, screening, diagnosis and treatment, and linkage to appropriate appropriate care and treatment, leveraging on the robust full patient management, case management team to provide appropriate follow-up and use of data to improve outcomes and the program implementation. This schema shows client flow through the facility to access appropriate services, dispensing of drugs for HIV and NCDs in integrated pharmacy. This Nigerian model entails full integration, and that's where the ultimate goal for us, where PLHIVs for ART initiation, return, or routine visit are offered screening for NCDs. Those with comorbidities are treated, monitored, and support provided at the HIV clinic as a one-stop shop. The HIV NCD integration started with pilot in 3 states, as listed there in the slide, and with 15 facilities being engaged, and 12,000 PLHIV were screened in the initial pilot phase, and the result of the analysis revealed that 6.6% prevalence for hypertension and 3% for diabetes. The HIV NCD integration has since then been scaled up to 39 facilities in 5 CDC-supported states. Monitoring and evaluation. This summarizes the target set for monitoring HIV NCD integration in this current fiscal year using customized indicators for monitoring of our program. And entails essentially that people living with HIV and having diabetes or hypertension are screened, diagnosed, and are aware of their comorbidities. And out of these, 90% of these should be linked to treatment, to prescribed treatment according to the guidelines. And out of those that are on treatment, that the 90% achieve control as specified per the guidelines. And that also ensuring that the HIV, the PLHIV achieve optimal HIV treatment outcomes as measured by attaining viral suppression and having been retained in care. So we also leverage on extensive monitoring and evaluation systems for HIV program across health facilities, include paper-based record, electronic medical record, assurance of data quality through capacity building and promotion of data use in form of dashboard, etc. And for results, briefly, I'll go through some of the results. This particular chart diagram shows the dashboard summarizing our HIV NCD integration effort. I'll not go into the details, and these are charts which are output from the HIV NCD module on the EMR. The top chart shows the distribution of patients by age and gender, while the lower one on my left hand reveals that higher proportions, there are higher proportion for high risk BMI with increasing age is noticed. And the lower chart to my right shows that the percentage of high risk BMI is disproportionately higher in females, with females have at 47% compared to males 41%. This chart is shows the HIV NCD cascade, specifically for hypertension, the cascade for hypertension. Out of 32,861 patients screened for hypertension, 17% were found to have elevated blood pressure, and 76% of those with elevated pressure were diagnosed as having hypertension, and only 3.4% of patients with hypertension are on treatment. And out of these, 73% have controlled hypertension. And the weakest link from this is evident is the cascade. In the cascade is linkage of patient to treatment. And basically, this is as a result of the fact that many in Nigeria, patient that's high out-of-pocket spending for healthcare, and as PEPFAR currently does not provide or support provision of NCD medication. Also, as a factor is in completeness of data, as we are still building while sealing, especially as it relates to longitudinal records for patient NCD encounters. Challenges and next steps. So I've mentioned some of the challenges. I'll not repeat them here in my previous slides, and I'll just proceed to the next slide.
Everybody has a chance to read the lessons learned. Colleagues over there, should we advance, or are you able to? fix the glitch. All right. Okay. Well, that session ended somewhat abruptly, I confess. Obviously, Dr. Onutu is not with us, so we're not able to take questions from him. So maybe we could transition now to our next speaker. I'm going to ask Dr. Lowe to join me up on the podium. Dr. Lowe is a member faculty at the University of Zimbabwe College of Health Sciences and a clinician at the Newlands Clinic here in Harare, and is going to share insights from their integrated model of service delivery. Over to you.
Can I look at the screen? Okay.
No, because it's a big delay on it.
Right.
Sorry.
It's fine. Good morning, everybody. Thank you so much for PEPFAR for inviting me to speak today. I'm really delighted to be here to share the experiences of a clinic that we've been implementing over the last 18 months, which is an integrated HIV geriatric clinic here in Zimbabwe. Next slide, please. So I'm going to give you an overview of the clinic itself. I'm going to talk about how we went about modeling the clinic. I'm going to focus specifically and in a little bit more detail about the screening tools that we use in our clinic. And then I'm going to end by sharing our results and talk a little bit about the lessons we've learned and our future plans. So just to give you a bit of context for those of you who don't know, Newlands Clinic is situated in a suburb of Harare. We are a non-governmental organization. We're Swiss funded by the Rudy Luti Foundation, but we work very closely in private-public partnership with the Ministry of Health. We deliver comprehensive outpatient care, which is free, to nearly 8,000 patients living with HIV. Currently, in our cohort, over a third of our patients are above 50 years of age. That's increased quite significantly since 2013, where 15% of our cohort were above 50. So in the last 10 years, we've observed what I call the changing face of the epidemic. And we've watched our patients aging with HIV, and we've observed the new challenges that brings. So for that reason, we decided to set up this integrated service. So the objectives of our service were to establish a differentiated care model for older people living with HIV. We wanted to incorporate the management of chronic conditions with HIV, but also assess geriatric syndromes and include management. We wanted to ultimately develop personalized care plans, so patient-centered cares, which is focusing not only on the delivery of ART, but optimization of intrinsic capacity and functional ability, which, as you know, are very important for quality of life of people who are aging. So how did we do it? Our model of care is based on, I've missed a slide. Let me go back. Our model of care is based on very useful and informative guidelines published by WHO in 2017. These are the ICOPE guidelines. So they recommend a comprehensive geriatric assessment which covers the domains which are shown here in the figure. Basically, the model of the clinic, we have 2 now specialized geriatric nurses who deliver a 90-minute interview, which is based on what we call our electronic history wizard. So all of the screening tools that we've selected are embedded in our wizard and delivered by the 2 nurses. After the interview, a doctor who's overseeing the clinic will then come together with the patient, do some more assessments, and then make a comprehensive personalized care plan. We did get some input from a visiting specialist geriatrician to check we were on the right track. She also did a little bit of training with our specialist nurses. So now I'm just going to move on to focus for a few more minutes on the screening tools that we used. So selecting the screening tools, the first step was identifying the domains we wanted to assess. So we did that as I've described. The next step was trying to find a tool that is validated in our population. Now, for some domains, that was relatively easy, but you can imagine that for others, a lot of the tools have not been validated regionally. So that was a challenge for us. The other thing that was important was that if it wasn't validated, we then looked towards local or regional guidelines who might suggest a tool that we could have used for that domain. And then lastly, we wanted tools that were feasible and relevant to our setting, but also practical. So the practical considerations were, was it easy to administer? Did it need much assessor training? Did it need special equipment? And then finally, this was not a research clinic. This is a clinical service for the people at Newlands Clinic. We didn't want to screen for something for which we had no intervention. We weren't trying to gather data. We were trying to provide great clinical service. So that was really important when we were choosing our tools. So I'm going to talk in detail about a couple of the domains, not all of them, because I've got about 5 minutes left. Thinking about screening for mental health was actually relatively easy. We used the PHQ-9 to screen for depression, the GAD-7 for anxiety. These are tools that have been well validated in Zimbabwe in people living with HIV. They're easy to use. We already use them at Newlands Clinic, and we're very fortunate that we have great psychological support on site. So if we identify a problem in these areas, we can refer to our on-site team. So then cognitive function, however, was actually much more challenging. How do we assess for cognitive impairment? An ideal tool in people living with HIV should incorporate both non-HIV related and HIV related causes of impairment. Now, to do that requires quite considerable, cumbersome testing and also specialist training. So we looked at a whole range of tools. I've shown some at the bottom. The MOCA has been validated in people living with HIV, the MMSE, but these tend to function on the non-HIV related causes of impairment, and they're not well used to check for executive function, which is really important when you're assessing for hand. We then looked on the other scale, should we be using things that are for HIV cognitive impairment? But again, these tend to underestimate cognitive impairment caused by non-HIV related disease. So the last thing we considered in this domain was actually, if we do comprehensive testing for cognitive impairment, what are we going to do once we find it? And the resources and the options are actually quite limited in our setting. There's certainly no pharmacological interventions, so what we could do was fairly limited. For that reason, we then decided on quite crude and simple testing of cognition, and we used an abbreviated mini-mental test, which is 10 questions, which assess short, long-term memory, and then orientation in time, person, and place. And then frailty. Frailty assessment was another issue. How are we going to screen for frailty? So putting together this clinic took us about 9 to 12 months of back and forth. It was quite a lot of planning to try and get it right. I think if we'd actually looked at all possible frailty screening tools, it would have taken us another year. There are many. A lot of them are validated in people living with HIV. Sorry, we've gone too quickly. Oh, now we're going backwards. So I'll talk without my slides for now. So we decided on 2 types of screening tests. One is the SPPB, and then the other was the Frail scale. So the SPPB is roughly takes about 10 minutes. It assesses mobility, balance, and muscle strength. It's carried out by our clinic doctor. And the Frail scale is essentially just 5 questions embedded into our electronic wizard. We were interested to see how they compared and how easy they were to perform. So the good thing about these is that they're validated in people living with HIV and relatively easy to administer. But if you look at my table down at the bottom, the 2 screening tools gave us quite different results. And I talked earlier about choosing tools that were relevant. So the Frail scale, there's a question about resistance here, which says, by yourself and not using aid, do you have any difficulty walking up 10 steps without resting? I'm not sure how many of you in this room are from Zimbabwe, but apart from the Rainbow Tower steps, How often do you actually walk up steps? For our population, it's almost never. The houses don't have steps. There's not many public places with lots of steps. So actually, the nurses very quickly told us this question is not useful in our population. And we actually stopped recording this, and you can see that you've got lower results using the frail scale. So that was an interesting learning point for us. So I said that we use the SPPB, that's demonstrated there on the left-hand side. After realizing the frail scale wasn't great for us, we looked at other scales, and then our doctor in the clinic introduced the clinical frailty scale. This tool is a summary of the clinical status of the patient based on the clinical encounter. It just is a number that assesses the patient from fit to frail. So we're trying to just simplify our approach as we go along. Again, one of the benefits of this not being a research study is that if it doesn't work, we change it and we try something else. So we are in a privileged position being able to do that. And then lastly, the last domain that I wanted to talk about is we try and do comprehensive screening of physical health. And this diagram is really just summarizing all those things. We look at NCD control. NCD management is already integrated into Newlands Clinic, but we look more into are these NCDs controlled? What are the complications that we should be looking for? We assess visual acuity using Snellen charts. We use a whisper test for hearing. We do have a dental department, so we encourage all the elderly patients to go to the dental review once a year. We look at nutrition using the mini nutritional assessment, and we look at bone density with the FRAC score, which has been validated in Zimbabwe. We had done some DEXA scans on a few of our patients, but we found that the results correlate quite well with the FRAC score, so we think that that's not where we should be putting our resources. The last three domains we assess using directed questions embedded into our wizard. So we assess geriatric syndromes, mobility, incontinence, falls using directed questions. We also screen for cancer using directed questions around prostate cancer, cervical, colon, and breast. And if any of those questions are positive, we then go on and do further testing. So to close, Dr. Tadarera showed our results in detail yesterday in one of the oral sessions, but this is the first 100 patients that we've seen in our clinic. The majority of these patients are female. That's reflected, that's our clinic population. What is important is that these patients have been in care a long time. The median duration of care for these patients was 15 years. So they've been coming to visit us at Newlands every 3 months for those 3 years. And I think that's why this first point is so significant, that following our comprehensive geriatric assessment, despite long-term care, nearly all the patients had some new intervention, 86%. So that was either a new treatment, a referral, a new diagnosis. And we really thought that was quite significant. If you ask, you will find problems. And there on the right-hand side, you see all the new diagnosis, which I won't go into for the because of the time. What was interesting is that we diagnosed 4 new cancers just by asking questions in our electronic wizard. So what I didn't say in the slide before is that every patient had a head-to-toe examination. Now, that might seem obvious, but it's not what we do during routine care, and it highlighted quite a few problems. So on the left there, we also looked at concomitant NCDs within this population, which were extremely high. We didn't diagnose any new ones, but I said previously that we already integrate NCD care. So 80% of patients had hypertension, 1 in 5 had diabetes, and nearly half had chronic kidney disease. Lots of comorbidities. The last really important point about our results is that these population had really well-controlled HIV. 100% of them had viral loads of less than 1,000, the WHO definition of suppression. HIV is not their problem. However, when we looked at the control of the NCDs, we're actually not doing as well. 73% of those with hypertension had good control. 80% with diabetes had good control. That's not the same as 100%. And I think that's a reflection on how we have prioritized HIV over the years. I think it's also a reminder that we have to change the way that we approach all of these chronic diseases. So in summary, what did we learn? We learned that it's really important to choose appropriate tools which work in our setting. delivering a CGA effectively with nurse-led care is possible and doesn't need much training and not many additional resources. And when you do the CGA, it identifies many problems. There's a very high prevalence of multi-morbidity, which had been previously missed in routine care. There are some limitations to our models. We recognize this is a very time-consuming exercise, and actually it might be better delivered over several visits. Also, introducing new tools and new screening into already overburdened clinics can be challenging. Understandably, but sharing these results with our nurses in the clinic has been really helpful to motivate them, to help them understand that this is really worthwhile. So what's our next step? Initially, our objectives were, let's make a great clinic. Let's make the best clinic we can for our patients. We didn't think about the wider context. On reflection, we were probably a bit overambitious. 90 minutes is a really long time. So the conversations we're having after 12 months of the service is, let's streamline it. Let's focus on those that really need it, although 86% of people did need it. And also, because a lot of this is around prevention, identifying cardiovascular risk, starting statins, establishing patients who've got osteoporosis, preventing fractures, should we actually start earlier? I think the answer is yes. So we're looking at the ICOPE primary health care tool, which I'll show you in the next slide, which is actually much shortened. And we're actually piloting now to see if we can identify those that really need a more comprehensive assessment. We really want to, in the future, utilize our data to inform integrated care into less well-resourced clinics. So to do that, we do have to streamline our service. And then finally, I really want to say what I think my colleague from Kenya was going to say, sorry, that's the tool, that if we really want to optimize healthcare for older people living with HIV, we have to work towards, we have to go beyond testing viral loads and supplying ART. We need to think about how we can reconceptualize HIV care and we can integrate more comprehensive assessment. So I leave you with a thanks to the whole team and some lovely feedback from our patients who seem to be quite like doing what we're doing. Thank you for listening.
Great. Thank you, Dr. Lowe. Yeah, please take it. Maybe. Oh, sure. Why don't I? No, stay on the stage, but we'll swap around. So we have Dr. Kiplagat from AMPATH in Kenya now, going to share experiences from your situation there. I think we need to run the slides from the beginning of the slide deck. So if you can help go back to the start.
Next slide. Okay. Thank you. Good morning, everyone. Thank you so much. My name is Dr. Kiplagat, presenting on behalf of my COP as well as our clinical care and population health lead. When you hear about AMPATH, the academic model providing health care, you will hear about AMPATH Kenya, AMPATH Nepal, AMPATH Ghana, and AMPATH Mexico. But today I'm going to focus on AMPATH Kenya, sorry. AMPATH Kenya, oops, the slides move so fast. So how do I get back? Oh man, okay, go back. Great, so AMPATH Kenya is a partnership between a medical institution, that's an academic institution, a public health sector, and a consortium of institutions within North America and as well in Europe. Moi University represents our academic center, and Moi Teaching and Referral Hospital represents our public health sector. So just a bit of numbers. Kenya has an HIV population of about 1.4 million. AMPATH takes care of about 120,000 of these patients through PEPFAR-funded, two PEPFAR-funded projects, that's USAID AMPATH Uzima and USAID AMPATH Dumisha. Of all Our patients, adult patients specifically, 30% of those are older adults living with HIV, and about 50% of them are living with hypertension as well. And in our analysis, we've seen that less than 50% of them are achieving hypertension. So we might get a few tips from Newlands on how they are achieving over 80% of hypertension control. But we've seen a lot of challenges that are faced by older people living with HIV, specifically social and behavioral, that's low testing issues, structural, increased risk of poverty, limited access to NCD services, along with limited mobility, and as well issues related to increased risk of multimorbidity. I can belabor on that, polypharmacy and frailty. That is what set us to wanting to integrate care as the AMPATH program. And how did we do this? We set out objectives. And, okay. Great, go back one slide. We set out objectives. So our first objective was to ensure that we're integrating to strengthen the continuum of care. 2, to establish a strong coordination system for our programs, but also to provide a platform for collaborative learning and adaptation. We are an academic institution with a tripartite mission of health, research, and training. And ultimately to ensure that the services that we provide are client and family centered. Beside that is that also our Kenyan HIV guidelines are promoting integration, that we need to screen, prevent, and manage specific NCDs, as this is also included within our standard package. AMPATH model on integration services is actually geared towards that. So naturally, of course, you would see integration of HIV and NCD. One, because these are 2 chronic diseases. 2 is that we often see the iceberg, in that there's lots of people out there that are actually not diagnosed, and we need to do that. We have in literature seen several integrated models, 5 of them in particular. 3 of these are currently being implemented in AMPATH. Case 1, where we're doing community-based integrated HIV and NCD screening services. We see case 3, where we've adapted existing HIV tools that are currently being used for an integrated HIV and NCD clinics. Case 4, where we have an integration of HIV and NCD in all inclusion of our chronic care clinics, and our population health model as well, that is supporting provision of care to meet the needs of our population and not focus on a specific disease. So giving the example within the AMPATH, we've done our integration from screening, referral, as well to care, treatment, and management and retention. So within the screening at the community level, and I know Newlands really focus on the clinic component, we in the community are screening our patients concurrently, or rather screening our population concurrently as part of our population care. And within the screening component, we have community health volunteers that we engage to do the screening. Beside that, we have our HTS, that's the HIV testing and counseling providers within the clinics as well. So they co-work together. Those community health volunteers screening for NCDs, if they find eligible participants to screen for HIV, they would refer them, they would work alongside the HTS and they do screening. Referral and linkage to strategies is very key. So what we do is that clients with elevated blood pressure specifically are referred to the clinics, to the clinicians within the facilities, the level 1 facilities through all the way and the referral care system. And then those who test positive for HIV, they have a same day referral system and they're linked to care. we have continuous follow-up by both CHVs and also the HTS within the community to ensure that those who test positive for HIV and those who have elevated high blood pressures are actually linked to care. Within the care and treatment, we have an integrated hypertension care within the HIV clinics. I think Dennis really provided similar program that we have within our within Kenya. And then integration within our outpatient departments where we have special NCD clinics that do offer care. And we have roving clinicians. NCD clinicians would move into HIV clinics to offer NCD care as well. And then access to HIV medication. Through funding from Grant Challenges Canada, we've been able to set up what we call revolving fund pharmacies. These are pharmacies that ensure that we have continuous supply of NCD medication, and this NCD medication is provided at subsidized price because the supply chain mechanisms that we are using is similar to what we use for the HIV medication through the KEMSA. Yes, and we have been able to develop about oops, sorry. I like the way these slides keep going and taking us far away. But what I wanted to, if you could go just one slide behind. So I talked about another slide behind. I have 2 minutes, but yeah, I'm going to make that. The supply chain is what I just talked about, the revolving fund pharmacy. What we do, we had seed funding from Grant Challenges, where we developed a revolving fund pharmacy. Medicines are sold to the patients at a very subsidized price. The money obtained is used to replenish the stock, and we continually just having that revolving fund. We have about 35 current full RFPs, and about 60 of them that do pick drugs and take them to the clinics that are spread across 6 counties in Western Kenya. Next slide, now that I don't want to just move faster. Yes, the next one is what we call group medical visits, and these occur in the communities. What happens is that a clinician visits a community. We have community members who have similar conditions, HIV, hypertension, come together into a group visit. These groups actually are formed as part of what we call chamas. Chamas are merry-go-rounds where people contribute, and they meet monthly. And within the monthly groups, they contribute their funds. As part of that, we have a clinician coming in. They serve several purposes. It's an economic empowerment component for our population. But beside that, part of the money that they contribute go into obtaining the National Health Insurance Fund or National Hospital Insurance Fund that will support their medication for their NCDs that are not provided free, thanks to PEPFAR, which provides ARTs. And aside from that, there is health education that is provided to these patients during those group visits, and the clinical care that takes place, and pill refill. So patients get their drugs brought in by the clinicians, both the ART and also drugs for their chronic diseases. My last slide really focuses on the challenges that we've had. One of the key ones is issues to do with healthcare financing. I think that has been talked about, where we have siloed care, we have free care for ART, thanks again to PEPFAR, but we have out-of-pocket payment by patients who are seeking NCD services. Disclosure continues to become a key issue where HIV is still a stigmatized condition. So within the group care, even coming out to say I'm living with HIV and hypertension becomes difficult. But otherwise, we're encouraging our patients, of course, to continue disclosing. Metrics for monitoring. We have very clear metrics for HIV, 95, 95, 95, but for NCDs, that's still a very gray area that I think needs more emphasis, and access to, NCD medication, of course, issues to do with stockouts and the expensive component of it. Thank you so much. Sorry for taking more time, but I want to appreciate and acknowledge the various support that we've received as a program.
Thank you so much. I think you'll agree that these are two really illuminating models for how to integrate NCD programs into care for people living with HIV. We have a couple of minutes for questions. If anybody does have a question, please raise your hands. Also, you know, if you have a model for NCD care from your setting, we'd also love to hear from that. But I see a hand at the far back. We'll start there and then we'll come forward slowly. And please introduce yourself as well.
Great. I'm Dr. Jacques Amango. I'm based in Namibia, working for the HIV program. Thank you to the presenter. I just want to learn more about the Newland geriatric clinic. So my question is, how's the setup of the clinic? It's only for geriatric, or you have also other services like adolescent, you know, young adults? That's number one. Number two, I don't know the setup for the city of Harare. Do you have a total number in the city of Harare of more than 50 years old, so that we compare to your clinic if we really need to scale up to expand these services? And my question again on retention, I asked this yesterday. So this one is to find out, did you map out where these patients are coming, the geriatric one? Because if your clinic is on the center of the city, you have some patients maybe coming from far, where they are other clinic, ART clinic, but they prefer to go there because of this package of services we are offering. Thank you.
Thank you so much for your questions. So Newlands Clinic does provide comprehensive care for people of all ages. So we have a pediatric service, adolescent service. This is just the newest addition to our sort of differentiated care. So it is comprehensive. And we also have dental services, mental health support. The third question was, do people come from other areas because they know about our services? That is absolutely true. But we are a secondary referral center now, so we do have now quite strict criteria for coming into care. And being older with HIV is not one of those criteria, but having complex HIV is. So people do self-refer, and then we make an assessment and we determine whether they qualify to be enrolled in the clinic. The second question, I've gone blank. So sorry, I should have bought a pen.
No, I think that's a good answer.
Okay.
In the interest of time, I think there were some other questions as well. I see Carrie has a question in the front, and then some in the middle of the hall.
Thank you. My name is Judy from Kenya, and thank you to all the panelists. And Empath is part of the work that you do. And it's quite a great care that you're giving to our adults who are living with HIV and AIDS. However, I want to talk about the non-communicable diseases that are showing up with the population. We agree that non-communicable diseases are preventable, and at some point they can be reversed if really arrested early. But the community part of it, in terms of our community healthcare workers' sensitization, yes, the screening is so good, what is happening, the physical, the nutrition, and the bit of it at the clinic. But when they get back home, I think there's some type of support that we need to give in terms of nutrition, availability of local foods that they can use, and also the mental setup to adapt into issues like cutting off sugars and other consumption things that we take locally for granted at home, but really spike our sugar levels and also affect our bones, including our local drinks, the sodas and other things. So the management, again, at the community is also another issue that we need to prioritize in terms of managing our community health promoters back at home and any other country that is using the community health promoters in terms of sensitization to work with these people at home after they have got all the information from the clinic. Thank you.
Thank you so much. I think that emphasis really focuses on what we continually work on and try and, innovate on. One of the things that we've been able to do is educate our, population. We are really not focusing even on just the patients only. We are educating on our population on food and food security related issues. We remember initially we used to actually provide food to our patients, but we moved from provision to educating our patients on how to be able to grow their own food and healthy food, have garden farms, you know, that they can be able to get green vegetables that they can utilize within the community. Beside that as well is the community groups do provide education. But now I would focus on the education of the groups alone. Maybe doing, you know, community education frequently will be something that would, you know, focus on as we continue both educating on lifestyle-related issues and what people need to eat for sure. Yes, thank you.
Hi, thank you, Carrie Johnson, USCID Cameroon. Thank you so much. This is really timely, great, as we talk about integration. Is the proportion of these NCDs higher in people living with HIV compared to the general population? If it is, then it seems like on the other side, as we work to control NCDs, just in the general populations in these LMICs, we may want to just incorporate specific guidelines for people living with HIV, meaning if people with HIV are at higher risk, we may just want to be working with those ministry programs for NCDs.